Hello and welcome to Psychiatry Grand Rounds. For today, I'm Jeremiah Hopkins. I'm the Chief Resident in Psychiatry, and I'm going to be doing the introduction today for Dr. Miller. Today she's going to speak with us about current concepts in grief. Now, Dr. Mary Miller, she received her MD from the University of Tennessee Center for Health Sciences, School of Medicine in Memphis. She also received an MS in Biochemistry from the University of Tennessee Center for Health Sciences, and completed a psychiatry residency at Duke University Medical Center in Durham, North Carolina. She came to ETSU in 1995, where she has served multiple roles within the department, including clinic director, associate faculty in graduate school, professor with tenure. Previously has also been chair of the department and is currently a senior member of the graduate faculty. She's also been highly involved with resident education on numerous topics, including presentations and service related to resident and physician wellness, self-care and burnout, PMDD, eating disorders, mood disorders, among many other topics. Honors include being a distinguished fellow through the American Psychiatric Association. She's also been inducted into the Gold Humanism Honor Society in the Quillen College of Medicine chapter. For multiple years, she has won the Roy Miller Award and been named to the Best Doctors in America. She's also won multiple years of teaching awards, including the Students Teaching Recognition Award for Psychiatry 2 and the Psychiatry Residence Award for Outstanding Service. She is also on the Board of Regents for the Southern Psychiatric Association and a reviewer for multiple journals and articles. We are very happy to have her speak with us today. So Dr. Miller, welcome.
Thank you. So does that sound okay? I forgot to test it. Well, my topic for today is a topic that I'm sure everyone in the room is familiar with, and probably you all have your own opinions about, that of grief. And although grief is a universal experience that probably everyone at some point in their life will experience at least some amount of grief, it's still a subject that's not very well understood within the field of psychiatry, and it's been the subject of much controversy in the last several years as the DSM-5 was being debated and created. So today I plan to talk about several different aspects of grief. So first, I have no conflicts of interest. And what I plan to talk about today include what is grief, what does it feel like, and how does it differ from depression? What are the DSM-5 changes regarding grief and bereavement, and what are their implications? And how can we best help our patients that have grief? So years ago, a classic writing of Sigmund Freud was written called Mourning and Melancholia, and Freud wrote, although mourning involves grave departures from the normal attitude toward life, it never occurs to us to regard it as a pathological condition and to refer it to a medical treatment. We rely on its being overcome after a certain lapse of time, and we look upon any interference with it as useless or even harmful. So this has been the traditional view within the field of psychiatry about grief. And I was taught when I was a resident, this is the one time that we don't want to jump in and interfere with the natural process. We want to encourage our grieving patients to allow themselves to grieve, but we don't want to give them a medication that would block their feelings. And if we do that, it might cause other problems later. So this has been the traditional view. Now, there are many types of losses that people can grieve, speaking of grief in the general sense. There's the loss by death, which is what I'm going to focus on primarily today. But other losses that can be grieved are the loss of a relationship, such as through divorce or a breakup, the empty nest phenomenon, job loss, a move where even though it might be a desired move, there's still the loss of the support system that was there before. Illnesses, loss of functioning, where there's a loss of one's previous capabilities. And any change, even one that's desired, like retirement, because with that change, there might be a sense of loss of the previous identity and some of the connections. But what I'm going to focus on today is loss through death. And so let me start by defining a few terms that are used almost synonymously. There's bereavement, the state of having lost someone close. Grief, the psychological response to bereavement, and mourning, which is the psychological processes after bereavement in order to come to terms with the loss. Now, most people cope with their grief pretty well on their own. And if you think about it, more than 2.5 million people die every year in the United States. And on average, about 1 to 5 people, close friends and relatives, are bereaved by each of these deaths. And most people who are bereaved weather this storm without any sort of clinical intervention. They often absorb the process itself and later can feel that they've been deepened by it. It may make them more compassionate to others as they go through grief. And it's certainly not something that we need to each be jumping in to prevent. I became very interested in this topic 4.5 years ago when my own husband died. So I had been married for quite a while. I'd been with my husband for 32 years when he unexpectedly died in his sleep without being sick a single day. And I was very devastated. We were very happy. And during that point in time, the DSM-5 changes were being debated, and there was a lot of discussion happening all over the country about what grief is and whether or not it should be an exclusion criteria for the diagnosis of major depression. So I found myself, while I was going through my own grieving process, in a variety of settings where people were talking about this. And I heard a number of statements made that really concerned me, that I thought were overly medicalizing grief. And going back to my own training, I was thinking, we don't need to be teaching everyone this, that they need to jump in and treat everyone who's grieving as if they have major depression just because of this DSM-5 change that's being proposed. And since the DSM-5 has come out, I continue to think that it's very confusing. So I've been really interested in this topic, and what I ultimately learned, I will share with you. And I think some of the DSM-5 wording is very unclear, and it was really footnotes that I found some understanding that I'll share with you later. So the loss of a loved one can be intensely painful, and as I was going through my own experience, one thing that I thought was a beautiful metaphor for what it felt like was that bereavement can feel like a personal earthquake, because what it felt like to me was like the ground was shaking under my feet, but not other people's feet. And other people didn't necessarily know that my own foundations were temporarily shaky. It can be intensely painful and disruptive. It's universal, but it's also unique to every relationship. So the grief I experienced when my husband died was very different than the grief I have personally experienced with the deaths of my mother and more recently my father. And I imagine everyone in this room has probably had some personal losses and experienced some grief, and some losses are much more significant than others. And I think a lot has to do with the strength of the connection that you have with the person that you lose. So how does grief feel? Well, first of all, it can be a real shock, especially if it's an unexpected death like the loss that I had. And at the beginning, you may feel very numb. And so it's very common for people as they go through the initial days after a loss to feel like they're sort of numb to the feelings. They can go through the whole funeral process and hold it together surprisingly well sometimes and not have the full emotional impact hit them till later. It can be very scary because there's the fear of living without that loved one, but it's also scary to experience grief because it's a very different thing. As I said, when it happened to me, even though I had been a practicing psychiatrist for over 2 decades when I lost my husband, I will say that the day he died, I really had no idea of what emotional journey I was about to go through. And so it's been a real learning experience for me. And when all this was happening to me, I vowed to myself, someday when I'm over this, I want to tell other people about it and help them to understand it, because it's not the same as depression. When people are grieving, they can have many of the same symptoms as people that are depressed. Crying spells, changes in appetite, changes in sleep, trouble concentrating, loss of some interests. These are all common symptoms of both grief and depression, but there are differences, and I want to highlight those differences today. And I'm really disappointed in the DSM-5 because I don't think it really does an adequate job of describing the differences. What I've done, because of these experiences I've had, is to seek out experts on grief. I went to an APA small group discussion where two of the people that were on that APA task force about this bereavement exclusion decision, and talked to them about research going on grief, and I've communicated with them since. So I want to share with you some of the things that I've been learning about current thinking. Grief, unlike depression, rarely causes feelings of low self-esteem or feelings of worthlessness. Instead, the common symptoms of acute grief, especially in the first 6 to 12 months, are recurrent, strong feelings of yearning. This is a big part of grief. This yearning to be with the lost one, to sometimes even a wish to die, to be together with the lost one again. And unlike depression, one of the hallmark characteristics of grief is that it comes and goes in waves. So it's not a continuous process like major depression is. Instead, you've probably all heard about the waves of grief. It can happen unexpectedly, such as when there's a trigger, when you see a reminder of your loved one, and it happens at holidays and at anniversaries. And so what can happen is you have episodes of feeling intensely sad and perhaps sobbing to a great deal, interspersed with periods of feeling okay and being able to laugh and enjoy things. And this is very different than major depression. There's a steady stream of thoughts about the deceased, and sometimes people can hallucinate when they're grieving. I did not, but it can happen. And there's often a struggle to accept the reality of the death and a wish to protest that this just can't be. And for some people, they can develop real feelings of bitterness and anger. So I've, over the years, treated many patients with grief, and sometimes they are just stuck in their anger. It may be anger about what the doctors didn't do, or that they weren't adequately warned, or that the loved one didn't take adequate care of him or herself. But there can be a lot of anger as part of grief. Also, during this acute grieving period, there can be a lot of physical symptoms, similar to the symptoms of major depression, which is part of the confusion, I think, which is part of why I felt the need to really give this talk, because it can be so easily confused. So some of the somatic symptoms may be uncontrollable sighing, digestive symptoms, loss of appetite, dry mouth, feelings of hollowness. One thing that I felt, I finally put the words to it. To me, I felt like I was bleeding inside. That was my metaphor during the time when I was most acutely grieving. Sleep disturbance, fatigue, exhaustion, weakness, restlessness, sometimes difficulty being organized, and altered sensorium. As I said, some people may even hallucinate. And there's often a feeling of being disconnected from the world and other people, maybe not as interested in things as you normally would be, or irritable. Our bodies have an instinctive mourning process that I think Freud was alluding to. So after a loss, we process the death. And eventually, if our grieving is healthy, integrate the death through a process that includes a lot of self-observation and reflection. And during this healing process, you typically will vacillate between bouts of confronting the pain and periods of avoiding it. The emotional pain and the positive feelings are gradually integrated, and eventually, with healthy grieving, you can achieve a state of integrated grief in which you can have more of a bittersweet acceptance, but it's no longer so overwhelming and so acutely painful. Our culture and our religious traditions guide us a lot in the expectations. So there are certain cultures that encourage a lot of grieving, and there are other cultures that encourage hardly any at all. And in our culture, as I'll mention here, there's a real misunderstanding about what grief may be. Certain religions have rituals that may help, both in suggestions about the timing and the extent of the grieving. So I have a few quotes for you here from a variety of authors that to me had some meaning. This one is from Elisabeth Gilbert. Deep grief sometimes is almost like a specific location, a coordinate on a map of time. When you are standing in that forest of sorrow, you cannot imagine that you would ever find your way to a better place. But if someone can assure you that they themselves have stood in that same place and now have moved on, sometimes this will bring hope. And that's partly my motivation today. From James Patterson, the weird thing about devastating loss is that life actually goes on. When you're faced with a tragedy, a loss so huge that you have no idea how you can live through it, somehow the world keeps turning, the seconds keep ticking. Megan O'Rourke is an author who wrote a book, The Long Goodbye, about her own experience of her mother's death. And what she wrote is, I wasn't prepared for the fact that grief is so unpredictable. It wasn't just sadness, and it wasn't linear. Somehow I thought that the first days would be the worst, and then it would get steadily better, like getting over the flu. But that's not how it was. And Joan Didion wrote a book that became a bestseller several years ago, The Year of Magical Thinking. Perhaps some of you may have read it. And what she wrote is, nothing I read about grief seemed to exactly express the craziness of it, which was the interesting aspect of it to me, how really tenuous our sanity is. So after someone goes through a successful, healthy grieving period, the integrated grief state includes feeling that you've adjusted to your loss, have a sense of interest and purpose again, ability to function, which isn't necessarily compromised with grief like it is with major depression, but you feel like you're yourself again. Your capacity for joy and satisfaction are restored, but you can still hold on to feelings of emotional loneliness, sadness, and longing. Still in the background, thoughts and memories of the deceased are accessible, but they no longer dominate your thinking all the time like they did at the beginning. But you can still have surges of grief that can go on for a long time, perhaps the rest of your life, especially in response to certain special days, like calendar days, that person's birthday, or holidays, or other reminders. There's often some amount of anger and guilt after the death of a loved one. And that anger can be seen in many forms, including irritability, frustration, intolerance, or annoyance. I remember blowing up at the pharmacist, which I normally would never do, because my prescription wasn't ready. And I said, but my husband just died, and I need it now. So some develop anger at God or bitterness, and I've seen this with some of my patients, that they have a real hard time accepting that this has happened. And it's, for some people, it can cause a crisis in faith, whereas for other people, it can actually deepen their faith. And it's very common for people to become much more interested in issues about faith after going through something like this, because it's a real existential challenge. We go through life pretending that we don't ever die, but when you lose someone really important to you, you can't ignore it anymore. Guilt feelings are common after a loss for real and imagined shortcomings, for what you didn't do to prevent the death, or that person, what you have done to make your relationship be better. So what to expect? The pain of grief will come and go, sometimes in waves or spasms. And there's grief for what was lost and also for the future. You can lose your sense of hopes and dreams and expectations for how you thought you were going to be spending the rest of your life. Sometimes the loss can resurrect old feelings about previous losses, and it can lead to confusion about your identity. This can happen in a number of settings. When you lose a spouse or when you lose a child, you thought you were going to be a mother or a father. There are many situations where that loss really challenges your thoughts about who you are. Another real truth about grief is that it affects family members differently. And I've seen this with some of my patients, where I think it's sometimes not clear to each family member that each other family member has experienced their own grief. It just may be different. And sometimes family members get angry with each other for not being supportive enough and not really taking into account that the other family members are going through their own process as well and also need to heal. So while I was going through it, I kept wanting someone to tell me what is normal, and am I doing this right? Am I grieving the way I'm supposed to? Because being a psychiatrist, I'd seen a lot of other people have problems, and I felt like I just need to do this the right way, and I had tried to study it like every other thing I've ever done in my life. So I got all these books, and I read about it, and I talked to people and tried to learn as much as I could about grief. And one thing about grief is that there's a lot of individual variation, and grief is very unique. And it's unique to the relationship. So even within a given individual, as I mentioned, each of your grieving experiences in life is going to be unique. I want to urge all of you to be cautious about judging other people for their grieving. because I've seen it myself in so many people, that they judge others for either grieving too much or too little. When I was a child, my parents judged one of our neighbors for hardly crying at the funeral when her husband died. Like, she must not really love her husband. And I realize now, that's very unfair to her. Similarly, sometimes people can judge an individual for appearing to grieve too much compared to others. And so, again, it's very individual. It takes much longer than most people think. Feelings of grief can recur throughout a lifetime, as I mentioned. And our society is not guiding us very well, because when you lose someone, most employers will give you maybe 3 days off, but that's not nearly enough. There are a number of situations that are more difficult to grieve. One of the worst is suicide. And I remind my suicidal patients of this all the time, because if a family member loses someone to suicide, it can be devastating to them, and it can be something that they struggle with the rest of their life, because suicide stirs up feelings of anger at the one who killed him or herself, guilt about why didn't I see it coming, why didn't I prevent it, as well as sadness, and it can be a very difficult thing to resolve. Murder, obviously, is very difficult to resolve, and again, there are a lot of angry feelings, which is pretty clear why that would be so. And then there's the death of a child, because parents are not supposed to lose their children. Children are supposed to live past their parents. So when someone of any age loses their child, it can be extremely difficult to handle. Miscarriage is another loss that's difficult to resolve. And in many situations, miscarriage is like an invisible loss, because other people may or may not even understand that the person was pregnant. There was no human being there that no longer is there, so other people may or may not realize that the person who had a miscarriage is grieving for some time. And then lastly, loss of a partner that's not socially recognized. There are some relationships where there's a stigma in society, gay relationships. Other people may or may not even realize that the individual with the loss is gay, much less that they might have lost their partner or a friend. So these losses can be more difficult. Some of the barriers to healthy grieving that can occur are the belief that it's not okay to be sad or cry. And this is especially a problem for many men who think that it's unmanly. I think our society gives women much more permission than men to cry. There's the fear of being seen as weak or losing control. Some people, when they're grieving and feeling this emotional pain, turn to alcohol and drugs, which is really a bad idea. It prevents the grieving process. It can create its own problems. And similarly, some who are grieving do very self-destructive acting out to try to get away from those feelings. There's a book that's out right now, I think it's on the bestseller list, called Wild. Have any of you read it? And I think there's a movie about to come out about it. Anyway, it's about a woman dealing with the death of her mother, and part of what she gets into are some very self-destructive behaviors. Another barrier to healthy grieving is social isolation. It's really important to have social support and have people to talk to when you're grieving. And if you don't allow yourself to receive that support, it can stand in your way. I mentioned the lack of social recognition for loss, and also sometimes if there are unresolved conflicts with the person who died, that can be a real problem in trying to get through the grief, which is very common for people to have issues that they haven't really worked through with their loved one. Social support is really important. It can be very healing, and it's something that we can all do for each other. But it can be withheld if other people don't really appreciate or are personally distressed by the loss. And it's less often offered after certain losses like divorce and miscarriage compared with others. But it's a really important ingredient in healing. And I'm incredibly grateful for the support I received, because I feel like the year after my husband died was my year of hugs. I couldn't go to the grocery store without getting a hug, it felt like, because it's such a small town. And so many people knew what had happened to me. But you need to have a realistic perspective on what you can expect from others in your grief. I've seen patients get angry that other people weren't being supportive to them enough. And that can become a real problem, especially if the other people are dealing with their own problems. Okay, so now let's talk about the DSM-4 and the DSM-5. In the DSM-4, the diagnosis of depression included that individuals with depressive symptoms lasting less than 2 months after the death of a loved one were excluded from the diagnosis of major depressive disorder. And this exclusion was called the Bereavement Exclusion. So basically what this said was that if it's been less than 2 months, no matter what's going on, you can't call it major depression if you're going to be technically correct by the DSM-4. When the DSM-5 was being created, there was a huge debate, and you probably I would guess that most people, how many of you heard about the debate, about the bereavement exclusion while it was going on? It was in the New York Times. This was something that was not just in the psychiatric literature, this became in the popular press. And so there were some strong fears that taking away the bereavement exclusion was going to cause doctors to medicalize normal grieving and rush in and give medications or other things to people that are in acute grief that may not be appropriate. So what happened was that the DSM-5, they removed the bereavement exclusion after a great deal of discussion. And what this means now is that major depression can be diagnosed after a loss if all the criteria for major depressive disorder are met. But what this does not mean is that major depression should be diagnosed after every loss. And this is my main point of my talk today, that just because they changed the bereavement exclusion and pulled that out, it doesn't mean that someone who's crying in your office when it's within, especially the first 6 months, necessarily needs to be diagnosed as having major depressive disorder. Even if you're going by that checklist of symptoms, they seem to meet much of that. Because grief and bereavement is not a mental illness, and uncomplicated bereavement is still in the DSM-5, but I had to hunt for it to find it. I found it in 2 places. It's in the back of the book under conditions, well, I'll get to that in a minute. Uncomplicated bereavement is mentioned as a V code in the back of the book, and V codes, I don't know if all of you are familiar with that, but a V code means something that's not a real illness or a disease. It's a behavioral health situation, but not really a disease. But it's also described in a footnote, which I think is very sad, that the explanation of normal grief, you have to look in the footnote of DSM-5 to really understand it. So just to remind you, I imagine most people in the room already know, the criteria for major depression are having 5 or more of the following symptoms for 2 weeks. At least one is either depressed mood or loss of interest or pleasure. Depressed mood most of the day, nearly every day, markedly diminished interest or pleasure, significant weight loss or gain, insomnia or hypersomnia nearly every day, so a change in sleep, psychomotor agitation or retardation, fatigue, feelings of worthlessness or excessive guilt, difficulty concentrating, and recurrent thoughts of death or suicidal ideation. And for this diagnosis, the symptoms cause clinically significant distress or impairment in functioning. And again, this is a footnote in the DSM-5. The responses to significant loss may resemble a depressive episode. Although such symptoms may be understandable or considered appropriate to the loss, the presence of a major depressive episode in addition to the normal response to loss should also be considered. So you may think they have major depression because the two can coexist. Acute grief can coexist with major depression. But this decision inevitably requires the exercise of clinical judgment based on the individual's history and the cultural norms for the expression of distress in the context of loss. So it's not that simple that you go by this checklist. There's a call for clinical judgment, and there's nothing wrong with not giving someone the diagnosis of major depression when they're acutely grieving. There's also nothing wrong with giving them the diagnosis if you think that it really applies. So let me discuss some of the differences between grief and major depression. And I was guided in this by these experts on grief that I met at the APA. So one of them is a woman named, whoops, I'm going to get to her name, I'm blanking on it. Anyway, Catherine shared with me a number of her own slides. Whoops, I need to go back. Oops. All right, I can do this. Okay, so she shared with me some of her own slides. As I've myself been trying to understand what does the DSM-5 come up with and what really is the difference. In grief, the predominant affect or feelings of emptiness and loss And the dysphoria or feelings of sadness decrease in intensity over days to weeks, but they occur in waves, as I've mentioned previously, that come and go and are often associated with reminders of the deceased. And positive emotions can coexist with the sadness and humor. And thoughts are primarily focused on memories of the deceased. Whereas in major depression, there's a persistent depressed mood that's there the majority of the time, and there's an inability to anticipate happiness or pleasure. The dysphoria, as I said, is more persistent and pervasive, and it's common to have self-critical thoughts and pessimistic thoughts. In addition, in the case of grief, self-esteem is usually preserved, and if there are any self-derogatory thoughts, it's usually about failings to the deceased, and thoughts about death and dying are generally focused on the deceased and possibly wanting to join them so that you could see the loved one again. But in the case of major depression, there are feelings of worthlessness and self-loathing that are common, and thoughts about death and dying are more likely focused on ending one's own life because of feeling worthless, undeserving of life, or especially unable to cope with the pain of depression. So it's very different. Now, how many of you are familiar with Redfield Jamison? I was guessing that probably some of you might have read this book. Redfield Jamison is a really interesting woman who is a faculty member, a professor at Yale, who is a psychologist who also has bipolar disorder and has been very open about her own experience. And any one of you, especially you residents who haven't read this book, I'd highly recommend it. An Unquiet Mind describes her own experience of bipolar disorder, both the depression and the mania that she went through, and she's a wonderful writer. But she wrote another book called Nothing Was the Same that describes her experience of grief after her husband died. So I have a few quotes from you for you from Redfield Jamison, where she describes her own perception of the difference between depression and grief from her personal experience. The capacity to be consoled is a consequential distinction between grief and depression. There is very little preparation for grief. I was struck by that, and I had not been aware of the saving grace of grief. There is very little saving grace about depression, and in fact, grief serves a very real sustaining function. I ended up being remarkably in awe of grief, but still there is no preparation. With depression, one of the many horrible things is you are dead to everything you value in yourself and in life. Whereas in grief, if anything, you feel much more intensely involved with life, an acute missing, an acute awareness of life. It's a very, very different state. People confuse them, but they are very different. And this is again Jamison. You come out of it genuinely stronger and with a much better understanding of the person you lost and yourself, your vulnerabilities and your strengths. Grief forces you to do a kind of introspection that is really remarkable. My mind knew that everything about me needed tending. Solitude allowed tending, and grief compelled solitude. Time alone in grief proved restorative. Time alone when depressed was dangerous. The thoughts I had of death after Richard's death were necessary and proportionate. They were of his death, not my own. In grief, death occasions the pain. In depression, death is a solution to the pain. My mood, fixedly bleak during depression, was not so during grief. It was mutable and commonly rose in response to the presence of my family and friends. I was generally able to meet the demands of the world. Even during the worst of my grief, I had some sense that this would happen and that the weather would clear. I did not have this faith during the merciless months of depression. I think this really captures it, and it's certainly similar to my own feelings about what it was like. So what do you do to help a patient who's grieving? How can you help someone to have healthy, normal grieving if it's uncomplicated grief? Well, first, it's important to recognize the symptoms of normal grief and provide education and reassurance that what this person is going through is normal, even though it may be so scary. It can include a lot of emotional pain, feelings of incompetence and uncertainty. It can include even hallucinations at times. The best thing you can do to help someone who is grieving, I still believe, as they taught me in my residency, is to encourage the person to allow them to grieve. It's important to grieve when you've had a loss and not to block that by alcohol or drugs or reckless behavior or just not allowing yourself to experience your own human emotions. But at the same time, it's good to encourage people who are grieving that it's okay to have positive experiences too. There's nothing to feel guilty about if they want to go to a party or have fun with a friend, because some people put this on themselves. You know, there have been societal expectations about widows and widowers, about what they should and shouldn't do. But it's the nature of grief that it comes and goes, and that the positive emotions can coexist. It may help someone who's grieving to be given a sleep aid, because everyone needs to sleep, and that's a real common symptom of normal grief. And especially encourage companionship and seeking out social ties. It may help for you or for the bereaved individual themselves to even educate their friends and family about what they need and about what they're going through. And you should monitor the progress to make sure that it's not turning into something more significant. Okay, so are there stages for grieving? A lot of people think this, and I thought this, that when you're going through grief, that you have a number of stages. And this stems back from the work of a couple of key figures. One was Elisabeth Kubler-Ross. But what Elisabeth Kubler-Ross did was to describe stages of mourning in people that were dying, not in people that were bereaved. So she spent a lot of time studying what people went through, for example, who found out they had cancer and knew that they were terminally ill. But it's not the same as someone who's just lost a loved one. Now, her work was similar to earlier work done by John Bowlby, who described infant reactions to separation from their mothers. And he too described a series of stages. So the stages he described when an infant is separated from the mother are protest, anger, sadness, despair, withdrawal, and disorganization. And similarly, the stages that Elisabeth Kubler-Ross described are denial. You probably have all heard of these stages. This can't be happening. This isn't for real. Anger, why is it happening to me? Bargaining, trying to bargain with God. If only, what if I quit smoking now, will you take away my lung cancer or something like that? Depression, appropriate response to great loss, and it's a necessary step. And acceptance, I choose life and I will live with my loss, may be thought of as the stages in the Kubler-Ross system. But there's another author who's done research on grief who thinks that there are a lot of myths about grieving, and that we really need to look more at the evidence, because when you think about it, a lot of what we have traditionally believed about the grief process was not evidence-based. It was based on old psychoanalytic theories that didn't necessarily have a lot of evidence to back them up. So what Bonanno says is that instead of stages that are sequential, many bereaved people experience the coming and going of grief feelings interspersed with more positive emotions, which agrees with what I've been saying today. Many describe waves of grief that come over them. And he speaks more of a dual process model where you cope with bereavement through both loss-oriented and restoration-oriented processes that occur simultaneously rather than going through sequential stages. So he also says that he thinks the respites from the sadness make the grief more bearable. Now, the reason that there's another concept that's been in our thinking system in psychiatry for many years that stems back to an early psychoanalytic paper written in 1937 based on 4 patients. And then this paper, called The Absence of Grief, the author wrote that these 4 individuals did not grieve adequately, and because of that, they had delayed grief later. And so it's been believed for many years that if you don't grieve enough, then it may come back to haunt you in some other form. And this is part of what I was taught in my psychoanalytically oriented residency program, that when someone has problems and sometimes they may not be fully able to resolve them, maybe it's because they didn't fully resolve a grief from the past. What Bonanno claims is that later research doesn't really confirm the existence of delayed grief for those who were well adjusted after a loss, and instead, most bereaved individuals are observed to have moderate disruptions in functioning during the first year, and only a very small minority have chronic symptoms. So, it's a question. Also from Bonanno, he says that many popular concepts about grief have no evidence for their validity, and in fact, the vast majority of those who experience loss have resilience. And it's common, as I said, to alternate between sadness and joy and he disputes the existence of delayed grief. So now I want to shift gear just a little bit and talk about another diagnosis that's in DSM-5 that's new. So if you look in the back of DSM-5, there is a section on conditions that need further study. So these are conditions that aren't formally recognized yet, but they're on the way, because a study group has found that there's enough evidence that this may be a separate entity that it deserves to be recognized, but it's still under consideration. So the new diagnosis is called persistent complex bereavement disorder, which has previously been referred to as complicated grief. And basically what this refers to is someone who, for at least 12 months for an adult or 6 months for children, is still grieving, who can't get past it. And there are a number of people out there that are like that. I certainly have a number of patients of my own who, even a year later or more than a year later, have persistent yearning and longing, the intense sorrow and emotional pain, preoccupation with the deceased, preoccupation with the circumstances of the death. And in this new diagnosis, at least 6 of the following 12 symptoms mark difficulty accepting the death, experiencing disbelief or emotional numbness over the loss, difficulty with positive reminiscing about the deceased, bitterness or anger related to the loss, maladaptive appraisal about oneself in relation to the deceased or the death, self-blame, excessive avoidance or reminders of the loss, a desire to die in order to be with the deceased, difficulty trusting other individuals since the death, feeling alone or detached from other individuals since the death, feeling that life is meaningless or empty without the deceased, or the belief that one cannot function without the deceased, confusion about one's role in life or a diminished sense of one's identity, and difficulty or reluctance to pursue interests since the loss or to plan for the future, like developing more friendships or activities. So these, you'll probably recognize, are very similar to what someone goes through in their acute grief phase, but for this diagnosis, it persists more than 12 months. And the disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning, and is seen as out of proportion to or inconsistent with the cultural, religious, or age-appropriate norms. Okay, are you feeling confused by now? I have gone through quite a bit of confusion myself trying to sort all this out and understand what the DSM-5 has done. And so this chart is another table that I borrowed from the expert on grief that I have befriended from going to that APA meeting. And so basically, complicated grief, when someone has complicated grief, they have complicating processes that are prominent and persistent, that go on more than a year, as opposed to uncomplicated grief, where the complicating processes are either absent, mild, or transient. And some of these processes may include being really hung up on if only the doctor had diagnosed it sooner, if only we had gone to the hospital a week earlier, but they can't let it go. And I've had patients like this, like 3 years after a loss, just still can't let it go. If only this other thing had happened, then they'd still be here. Or excessive avoidance and health-impairing behaviors, as I've talked about before. Ineffective emotional regulation. Acute grief persists with all those symptoms I just discussed, and difficulty accepting the finality of the death with persistent yearning. In contrast, those who have uncomplicated grief, as I've mentioned before, the acute grief gets transformed into integrated grief, where there may be pangs of grief, but they're lessened in frequency and in intensity. The acknowledgement of the finality is there, and the memories of the deceased become less and less painful and can become very pleasant. And social engagement and pleasure in life return. Okay, then what's the difference between complicated grief, this new diagnosis in the back of the DSM-5, and major depression? Because now we're being told that we could call someone major depressed even from day one, well, no, after 2 weeks. So, which is part of what made me want to do this talk. The idea of giving anyone a diagnosis of major depression 2 weeks after they just had a loss, you really want to do that? So here are some differences between major depressive disorder and complicated grief. In major depressive disorder, yearning and longing are not usually seen. There's a pervasive loss of interest and pleasure. There's a pervasive dysphoric mood across situations. There's a preoccupation with low self-esteem. The general sense of guilt or shame and a general withdrawal from activities and people, and intrusive images are not a prominent feature. In complicated grief, there's a persistent, intense yearning and longing for this individual that's been lost. and things that are unrelated to the loved one are less interesting. Pangs of emotion are triggered by reminders of the loss, and there's a preoccupation with the deceased. Guilt and self-blame may be focused on the death, but are not pervasive, like I'm a bad person. It's more, why didn't I do such and such to help prevent that death? Avoidance of activities and situations and people that trigger reminders may occur, and there are frequent intrusive images of the deceased. But usually there's a trajectory towards gradual improvement. So what can you do to help someone who's got complicated grief? We've already talked about some things to do with people that are hopefully doing normal, healthy grieving. Well, this same person I've been mentioning, her name is Catherine Shear, and she has shared with me a paper that's currently in press, and she's written a number of other articles about therapy for complicated grief, and in fact, she has a Center for Complicated Grief that she's established, and I'll show you their webpage in just a moment. But she has developed a complicated grief therapy that's about to be published that's based on some attachment theory work and other therapies, and it has several key components. One is encouraging people who have this complicated grief process to write in a grief monitoring diary. So this is similar. You remember last week we talked about PTSD and how exposure may be, for those of you who were here, how exposure may be a key to helping people resolve their PTSD, but it has to be done carefully and slowly. Similarly, complicated grief is seen as being somewhat analogous to PTSD in terms of it may help this person to have exposure, to become desensitized to this thing that they just can't accept. So it may help to have revisiting exercises in the imagination, including exposing oneself through memory to the death itself and to memories of the loved one and imagining a final conversation. So in this paper that's soon to be published, which she's already shared with me, what the therapist may do is have the bereaved individual who's stuck in their grief make a tape recording where they recount what happened the day they learned their loved one died. And take that tape recording home with them and listen to it every day that week. And then the next week, make a new tape recording and retell it. And over time, the story will gradually change. Also, it may help them to imagine having a final conversation with their loved one, what they would say to them if they could right now. Another component of this complicated grief therapy that she's developed, though, is the restoration focus, encouraging people to allow themselves to have rewarding activities and envisioning goals for themselves, not to just stay mired in the grief at all times. There's a paper that just came out very recently that looked at 80 individuals who were grieving, and they did a randomized clinical trial where they gave all 80 individuals cognitive behavioral therapy for 10 sessions, and then they randomized them into getting 4 additional sessions of either exposure therapy, similar to what I've just been describing, or supportive counseling. And what they found is that the addition of the exposure therapy was found to be significantly more effective in reducing depressive symptoms and improving functioning. So that may be something we can do to help our patients. So what can the bereaved do, and what can you advise patients and friends and family members as they're going through grief? Well, one thing is to look for support. It's really important from those who can listen non-judgmentally and with acceptance. But you have to really look, because not everyone is able to be a good listener for someone who's grieving. Expect to talk about the same things over and over again, and you might want to warn your friends, or tell your patients to warn their friends that you're going to need to tell it over and over. Encourage your patients to develop a new sense of themselves and their identity, and to try to take on healthy new ways of being in the world without their loved one. And when the time is right, find new people, new friends, new objects or pursuits to invest in. It may be very helpful to plan ahead for holidays and anniversaries. I had a woman who I call my grief mentor when I was going through this, who was the chair of another department who also had experienced grief, who helped me a lot. So I saw her a few months after my husband died, and she suggested, I was really dreading Christmas, and she suggested do something really special with your children that's totally different from anything you ever did before. And I did that, and it was really great, because, and in years to come that may be helpful too, preparing ahead for holidays and anniversaries. Be assertive and share your needs. Avoid isolating yourself. Read about grief. Journal your feelings. One thing about journaling is if the person that you lost was your primary confidant in life, journaling is a way to become your own confidant, where you can write down your feelings every day and kind of get it out of your system and work it through. Expressing feelings without shame. There's nothing to be ashamed about being grieving. And exercise is a really wonderful thing to do when you're grieving. It's amazing how a 30-minute walk can help anyone who's experiencing depressed or anxious feelings to feel better. This is the web page from Catherine Shear's website for the Center for Complicated Grief, which I thought was really beautiful. Grief is the form love takes when someone we love dies. And lastly, here's a quote from Elisabeth Kubler-Ross, who, although her stages I have some questions about, she has written a lot about grief in general, and this quote is, "The reality is that you will grieve forever. You will not get over the loss of a loved one. You will learn to live with it. You will heal, and you will rebuild yourself around the loss you have suffered. You will be whole again, but you will never be the same, nor should you be the same, nor would you want to." And here are a few resources that may help individuals who are bereaved, that are self-help books. There are support groups around that churches and funeral homes have. There's something that anyone can enroll in for free called Grief Share that gives Christian messages for 365 days. And in summary, my main points are: normal grief differs from major depression because of the presence of positive emotions, the yearning, searching, preoccupation with the deceased, the symptoms directly linked to loss rather than to low self-esteem. It's not associated with impaired functioning necessarily, and it's part of a restorative process. And finally, all bereaved people should not be treated the same. For normal grief, they need support and monitoring. For complicated grief, they might benefit from a complicated grief targeted approach, although these are still being developed. And for major depression, or something that seems similar to PTSD, they may need to be treated with standard methods. But remember, therapy is as effective as medication for mild to moderate levels of major depression. So I think it'd be a huge error in our field if we start giving SSRIs to every grieving individual because of the DSM-5. They need to grieve. And here are some of my resources. So that's all I have, and I'm very open to questions. Yes. Hold on 1 second. He's going to bring you a microphone.
We differentiated grief, complicated grieving, and then depression. Now, as I see it, and I want to make sure that you misread this, depression should be, if you give a diagnosis of depression, it would subsume anything else. It would not, I don't see how you could give grief and major depression, because depression is unwavering loss of interest, etc. So I would see that as being sort of the, once you give a depression diagnosis, you really cannot give anything else. If it's post-loss and death. So that's one thing I wanted to make sure I understood correctly in what you said.
Yes, I would agree with you. If you think the person really has developed major depression, then you wouldn't, technically speaking, also give the diagnosis of uncomplicated grief. But they may still be grieving, and so I'm saying that they can coexist. But yes, uncomplicated grief is a V code. So V codes are not used if someone fulfills all the criteria for something like major depression. It's my understanding. Now, V codes are not something I've typically used very much, but anyone disagree?
Let me go on with the other questions. The other thing that I wanted your opinion on is, one of the aspects you mentioned as far as people wanting to die is that some people get suicidal because people get suicidal when they have major depression potentially, but also that in grief they may want to join the dead person. Now, I have some concerns if it's to the level, if it's not a fleeting thought of wanting to be there. If there is persistent thinking of wanting to join someone, I think that may be a harbinger of starting to move from maybe there's major depression that actually is there, that we haven't maybe asked enough questions, because typically people who have this self-esteem are not looking to end their life, down in terms of joining the dead.
Well, we all die. So I think the difference between wishful anticipation that someday you'll see your loved one again versus wanting to kill yourself. And that's, I think, what you see more in grief is someday I'm going to see that person again.
Right, so that's not what part of the training is. It's not a wish to kill yourself to join the.
It's certainly
That's
some.
more concern.
I agree with you that that would be of much concern and something to always look for.
And then the last thing really is that one of the concerns also, I think, much as, for example, people who are pregnant, you get unnecessary, uninvited advice about what they think pregnancy is like. I think it's important to make sure that just because someone grieved, as you said, it doesn't mean somebody else's process of grief is the same. So just sharing, how you dealt with it may not automatically be the blueprint for someone else.
I couldn't agree more. That's why I put in that slide about be careful about judging other people. I strongly agree with you.
What about group therapy? How useful? You hear about a lot of grief groups. What do you think about that? How useful is that to you?
I think it varies a lot. I tried it myself when I was going through my acute grief stage. I went to 2 different things. One of them I found very unhelpful, and the other one was more helpful. The one that I liked was more educational. I think it varies with the person whether it might help them, but it might help.
Mary, thank you very much for this. I wanted to share some anecdotes that might be interesting or instructive to the group. The first is that, if I remember correctly, we actually owe the existence of the biopsychosocial model to grief. George Engel got turned on to that, if I recall correctly, by an anniversary reaction he had to his brother's death. When Engel himself had cardiac symptoms. Brother. I think that there are ways that all of this can be expressed that we don't necessarily immediately see as grief, and I'd like to share 2 that happened in my family. The first was my grandmother, who lost a daughter at the age of 20 to a strep-induced cardiac problem that occurred 6 months before penicillin became widely available. When my grandmother was in her 90s and was aphasic, unable to communicate, and probably disoriented by any mental status measure that you would have given her, she still wept every year around the anniversary of that daughter's death. Somehow she just knew. The second example from my family occurred when my maternal uncle died of colon cancer at the age of 76. His father had been living with him. When my cousins told my grandfather that his son had died, he said, "It's not supposed to happen this way." He went to bed and died that night himself, and we buried them both the same day. The last point I wanted to make has to do with the developmental entanglements that can occur with this. So there's a large literature showing that losing a parent when you're a young child is a risk factor for subsequent depression as an adult. There's another pathway, I think, that's also more subtle, and that is losing a sibling or having a parent who has a miscarriage can affect the parent-child relationship in a way so that even though the child may not have had the kind of relationship that allows the child to grieve because the parenting relationship is altered, the child can be indirectly affected. The most dramatic example that I'm aware of is a case in which a woman had a late-term miscarriage. She apparently had a dissociative reaction, didn't know what to do with the expelled fetus, and put it in a roasting pan and just shoved it in the oven in her kitchen. Her young daughter saw it in there, reached the magical conclusion that Mama was cooking babies, and was traumatized by that. She was speechless at the time and was talking about it in therapy when she was in her 20s.
Wow. Well, those are some pretty dramatic stories. That first one, the first part you were talking about, I appreciate you underscoring that sometimes it can happen without you even consciously realizing that it's the anniversary. And I think that can happen to anybody, that they start feeling sad and may not even remember what today is. And then they realize, oh yeah, that's why I'm feeling that way today. Other comments or questions? All right, well, thank you very much.